Hi, I'm Dr. Donald Jurovich, and I'm a professor at University of North Dakota in the Department of Geriatrics. Today, we'd like to do a presentation on quality improvement using the age-friendly healthcare framework. This is part of an effort that's nationwide that is supported by HRSA through a federal grant called the Geriatric Workforce Enhancement Program. And there are multiple presentations on different geriatric topics that are located at the website that you can see at the bottom of the slide at the Dakota Geriatrics program. The goals today are to ask why better care is needed for older adults in this current climate. We also want to figure out why age-friendly healthcare is an ideal model to create better care for older adults, and then accepting that model to consider how we can best apply the geriatric 4Ms in your workflow. You can take a moment to complete the pre-test questions here. So the first question is, why do we need to adjust our clinical approach to the older adult? And the answer may be a little bit complex, but in essence, it relates to the continuum of changes that occur as individuals age. And more specifically, as you can see in this pictorial representation here of the spectrum of frailty and changes that occur with the older adult, is that there is a period in everybody's life where around 2 to 3 years before you pass away, the individual will experience a either pre-frail or frail state in most circumstances. And with each clinical encounter, we want to try to emphasize our older adults and help them stay in the very fit to well category and less so in the frail category. And there's actually evidence to indicate that we can reverse the process with a good medical intervention plan. We know the compelling reasons for focusing on the older adult population is that there are a lot of the boomers occurring over the next decade or so. The medical complexity increases with increasing age. Certainly a good portion of the older adults have 4 or more chronic conditions, which adds to that medical complexity. And then interestingly, 80% of medical costs are consumed in the last year of life, which all relates to futile healthcare that we need to be mindful of and to be guardians of for not only improving quality, but lowering costs of healthcare. So in consideration of the older adults in the healthcare system, we want to emphasize the issues related to medical complexity and frailty. They have many geriatric conditions, including falls and memory disorders. We're fortunate at Sanford Healthcare to have a strong geriatrics program to help guide some of these assessments and interventions for optimizing healthcare for the older adult. But basically, we want to disseminate geriatric assessments, management plans, and practices into primary care. So basically, all the boats will rise with the tide, if you will. So one of the questions is, how do you apply evidence-based medical care to the older adult population? And I have a case report here just to illustrate some of the conundrum. We have a 93-year-old retired businessman who lives at home by himself. He's functionally independent with maybe a little bit of assistance in his finances from his family. And he comes to the clinic having had a fall with a head contusion and expresses brain fog after this jogging incident. Excuse me. His son says that he's concerned about the patient's judgment because he was running in 100-degree weather. and he thinks his father may have had a heat stroke and continues to be a little off. So the question is, what is your differential diagnosis at this point? And increasingly importantly, we need to consider as to how would we align a healthcare plan with what matters most to this patient who clearly wants to be physically active. So that's just as a setup to guide us through the additional questions here, is that as we consider better care for the older adult, how can we follow best practices from the research? So each time there's increasing evidence for a particular intervention, how do we apply that to our clinical practice? And that's part of our interest in quality improvement. The other part of quality improvement is to consistently apply evidence-based medicine. And so in the case of the age-friendly healthcare program, consistently applying the geriatric 4Ms is one of the metrics that we would want to use for appreciating the application and the consistency of the quality improvement program. So we want to focus on the so-called geriatric 4Ms. It's what matters, medication review. Mentation is now being called mind as a little bit more or less pejorative term, and then also mobility. And each of these 4Ms need to be delivered reliably with each clinical encounter across the continuum of healthcare, whether it be in primary care, long-term care, or acute care. So one of the questions is, how do we get to the point of providing better care for older adults? And I think it's a twofold or two-point path. One is to increase our geriatrics knowledge, and then secondly, to apply that through specific assessment tools and action plans that are evidence-based. So you might ask, well, what kind of knowledge do we need to provide better care for older adults? One of those at the top of my list is recognizing atypical presentations of common diseases. So, that patient that comes in with belly pain who actually has community-acquired pneumonia. Another element is recognizing two forms of delirium. So there's hypoactive, which is more frequent than the hyperactive version of it. Another element is to recognize depression, which may be more of a somatization rather than somebody saying, I'm depressed. Another knowledge base is to understand geriatric syndromes, such as recognizing frailty. If somebody comes in with temporal wasting, as you see in this picture here, what are the implications for that in their health care? We also want to be able to estimate remaining life expectancy. Patients and family members are notoriously bad at predicting lifespan, and often they overestimate. A lot of times they don't understand the lifespan or the average lifespan expectancies with their multiple chronic conditions. So we want to walk through and have an introduction to all of these 4Ms and how do you assess them. So with the what matters, basically we want to focus on their advanced care plan, but more importantly, we want to ask them what matters most to them. What are their health goals? And I just mentioned here that the Stanford letter is a nice tool that you might want to look at for helping patients communicate to you what their life mission is and what their hobbies are and what's most important in terms of their healthcare plan. In terms of mind, we use PHQ-2 for depression and Minicog for memory loss. There are other tools that we might want to add to the regimen, such as social isolation and loneliness scales, and then the confusion assessment method, or the NuDesk, which is used at Stanford for delirium screening in the hospital setting. In terms of mobility, we like to use gait speed. Anything less than a meter per second is considered at risk for adverse health events such as falls, acquisition of dementia, and hospitalization. Doing the Sharp and Romberg test, where you do a foot-to-foot tandem stance, is another screening tool. And if they're unable to hold that stance for 10 seconds, then they're screened positive for falls. Finally, the other 4M is medications, and we would like to have checklists to routinely identify unsafe medications in the older adults. So the question always becomes, what are the action plans when the 4Ms are either screened positive or screened negative? So for instance, in the what matters most category, if they're screened positive, you want to get the advanced care plan minimally or the PULSE completed. And then if they've got that documented, then at that clinical encounter, you might ask the patient if they need to revise or update their advanced care plan, because a lot of these advanced care plans were put into place maybe 5, 10, even more years ago. How about the action plans when the 4Ms are screened positive or negative for the 4M of mind? Well, certainly if you screen positive for depression and dementia, you want to treat those both pharmacologically and non-pharmacologically. If they're screened negative, it's an opportunity to promote primary prevention of these conditions, particularly with brain health, in advocating for tight blood pressure control, vigorous exercise, and the literature is now supporting more is better in terms of reducing cardiovascular risk and vascular dementia, as well as nutrition and cognitive stimulation. How about the action plans for a screen positive or screen negative mobility assessment? So if somebody screens positive for fall risks, you want to have them referred to the fall team or physical therapy, preferably to the fall team. You want to prescribe specific exercises for core balance and strengthening exercises, which are strengthening probably more important than anything else. And then likewise, if they screen negative for falls, it's an opportunity to do primary prevention of falls. There's a recent study, for example, that shows that Nordic stick walking enhances overall physical performance. In terms of screening positive or negative for unsafe medications, certainly if somebody's identified as having an unsafe medication, we'd like to find ways to either deprescribe it entirely or to reduce its overall levels. And then in our practice, to try to avoid prescribing unsafe medications such as muscle relaxants, sedatives, and anticholinergic medications. So it would be a legitimate question asked that if you apply the 4Ms, what will happen? And basically, the literature supports the higher quality of life for the older adult. From a health systems point of view, there's lower costs, resulting in better outcomes, as well as improved diagnoses, because 80%, for example, of people who are cognitively impaired go unrecognized in primary care. So that's a good example of identifying a new diagnosis. So the question is, how can you apply the 4Ms? And firstly, we want to have everybody understand what the 4M assessments are and what the ideal management plans are. It's a dynamic process, and whereas the management plans will evolve with the medical literature. And we basically would like to redesign the workflow to include the 4Ms, because some of the stuff is already being done, and we just need to have the 4Ms better documented in our clinical encounters. And then ultimately, we'd like everybody to become an agent of change and to promote quality improvement and to measure what impact our changes are having on healthcare outcomes, which might include things like reducing fall rates in our clinic. It might be reducing hospitalization use, maybe even reducing nursing home use. So these are all parameters that we would look at once we establish the 4M framework. This is all based upon a plan, do, study, act cycle of improvement. And we want to have different checkpoints where, what's the fidelity? Are we practicing the 4Ms on a consistent basis? And then we want to eventually evaluate the project impact. And so I gave you those examples there. I think one of the most important targeted areas are reducing falls with the older adult population in our clinic because the CDC indicates that there's been a 150% increase in fall rates over the last 10 years. And so to me, it's a high priority area. So just to summarize, we know that older adults are at increased risk of harm, that they have disease in late life that often presents differently, and we need to be vigilant of that when people present to the clinic. We are looking forward to providing better care through the 4M framework, and that the impact of this model of care really depends on leaders and agents of change who, on a continuous basis, think about ways to make things better. And so we would like to encourage the thinking about the 4Ms. And just to give you an example, one of our geriatric fellows said that, I keep asking this question about what matters to older adults, and they just don't seem to, it doesn't seem to resonate with them when I ask them, what one thing can we do for your healthcare to make you do X better? And so he's changed the format into asking them what's most important in their healthcare, what are their healthcare goals, and just simplifying that question. He's found more traction for identifying what matters to the older adult. So a good example of leadership in medicine. And I appreciate your attention. And this is the post-test questions for this module. Thank you for your attention, and I look forward to our interactions on the application of the 4Ms assessments and managements.